generation. So that's why we have chosen this topic today. And the theme for this year is Let's Talk About Dementia. Last year too it was that, let's talk about dementia, and we are going to talk about risk reduction and prevention. And we are privileged to have three eminent speakers, three of them who have done a lot of work in this area. They're very knowledgeable: Dr. Suvarna Aladi, Dr. Manjari Tripathi, and Dr. Amit Dias. So even I look forward to hearing what they have to say, what are the new things we can learn, especially since the Lancet report has come out. And I'm very happy that Dr. Matthew Burgess has agreed to be our moderator for today. He is a member of the Scientific and Advisory Committee for ADI, and he also has been a coordinator for our ARDSI's Medical and Advisory Committee for several years now. So once again, a very hearty welcome to all of you, and over to you, Matthew, now.
Good morning, everybody. It's good to see that there are over 90 people as participants on this webinar. And I think we will start without much ado. And there are three speakers for today, and I will introduce them as we go along. The first speaker would be Dr. Manjari Tripathi. And I think each speaker is going to get about 15 to 20 minutes. So we have the presentations in about under an hour. And then we're still left with about half an hour or so for questions and answers. So many of you, if some of you are familiar with the chat box, you can, on the top of your screen, you can look at the chat box and then click on it and then type in some things to chat. Or if you want to ask some questions, you can put up your hands and then ask a question. You can raise hands and ask questions. So we will come to the questions right at the end, because the three talks are fairly similar in theme. So we will not stop after each talk to do questions. So Dr. Manjari Tripathi is a professor of neurology at the All India Institute of Medical Sciences in Delhi. She finished a DM from NIMHANS. So we've all had the pleasure of knowing her for many years. She's been very active in the ARDSI Delhi chapter. She's got many projects, and she's been a very prominent member of the ARDSI chapter in Delhi. And then she's also in charge of the Cognitive Disorders Clinic in the AIIMS in Delhi. So Manjari, if you're ready to go, we will have you on with your slides.
Am I audible?
Yes, I can see you're in full.
Am I audible?
Yes, you are very audible, and we can see you.
So I have a request. I am in this full horrible, dreaded looking, contraption because my OPD is running. And really, I would, request the chairperson to take my questions right after my talk so
okay,
that
Manjari.
I can, I'll try to attend in between the OPD, but I'm not sure what will happen towards the end. So okay. This is a humble request, and
no problem, Manjari.
With this, I'd start my screen share. And good morning to all of you, part of the cognitive, and dementia community. I think this is a wonderful thing. It's a wonderful idea to have the program online, because you get to, hear everybody and be at your home or be at your workplace, and really don't have to travel in these troubled times. At the outset, I'd like to thank ARDSI for having me here and to discuss a topic which is very close to my heart. I'd also like to thank Narendraji especially, and Meera, and my colleagues, Dr. Matthew, Suvarna, and Amit, who've been in this journey. It's a difficult journey to even discuss and think of research and, talk about Alzheimer's, because we are pretty much marginalized by major forces, including COVID. So, so I've been asked to talk on the risk and prevention of cognitive decline. I'll start with addressing the issue of risk. So what exactly is risk? Now, risk is something which, if we take a disease, say, for example, the easiest to understand will be, say, lung cancer. And we know that if we smoke a lot, we are likely to get lung cancer. And if we don't smoke, we are less likely or we will not get lung cancer. So a definitive risk, a causal risk, is something which X number of people are exposed to, and they will develop the disease to a great certainty. And if you remove that factor, that disease will not develop. That is a definitive risk. There are other categories of risks, and those which do not have the second part of it, that is removal of the risk, either in terms of studies or trials, are not really definitive risks, because removal of that risk is not removing the disease. So that's what a risk is. And sometimes the risk hits us like a ton of bricks, just as COVID has hit us right now. Now, what are we dealing with here? We are dealing with a cognitive disorder, which is very complex, very multifactorial, very multidimensional. And that's Alzheimer's, or maybe vascular dementia or frontotemporal dementia in different amounts and severities. We still are like these blind men looking at that huge elephant of the disease from various angles. So somebody who's a geneticist is looking at it from the genetic angle. Somebody who's a nutritionist is looking at it from the nutritional angle. Somebody who's, a person who believes in physical activity is looking at it from that angle. So everybody is trying to look at this complex disease from various angles and to evaluate what are the risks in these particular angles, and really whether elimination of that will prevent the disease. So that's what all of us in the field of Alzheimer's are trying to do. But then let us be sure, what are we dealing with? We are dealing with a facility of the body and nature, which is the cognitive reserve. Now, what exactly is this cognitive reserve? The cognitive reserve is the ability of the body and the brain to resist the effects of disease. And this is by modifying various life course experiences. Those with a higher cognitive reserve tend to have better outcomes. And this is, for any level of pathology. So we are trying to, in Alzheimer's field or in vascular dementia, FTD, trying to work upon various factors which affect this cognitive reserve. And hence, we have to be more sure about how multifactorial it is. Why are we trying to address this in terms of risks and prevention? Because if we work upon factors which affect this cognitive capacity of ours, maybe we can slow down the disease. Maybe we can push or stave the disease by 5 to 10 years or a decade. So that's why we all are focusing our efforts on this. Now, what exactly is responsible for this cognitive capacity or cognitive reserve of ours? How does it, how is it that it is modified? Well, some of the factors which affect this cognitive reserve are unmodifiable. You really can't change them. You can't change the genetics unless you do some genetic manipulation in utero or before the disease starts. So the unmodifiable ones is the genes which one person is born with, whether it be the particular chromosomes, chromosome 21, chromosome 1, whatever, whichever chromosome, or whether it be your ApoE or certain other mutations like presenilin mutations. So really you can't modify these to a great extent. Nor can you modify the fact that we all are aging day by day and moment by moment and year by year. So these are essentially the unmodifiable, non-modifiable risk factors for developing cognitive decline. We can't do anything about these two. But there are several factors which are imminently modifiable and must be modified. So these are like various biomarkers which we may have, various physiological factors, psychological lifestyle factors, etc. And they are modified by various things. They're modified by how we interact with the environment, how we sleep, how our mood is. And so essentially the unmodified genetics is like a loaded gun of which the trigger is the environment. I request non-speakers to please mute their inputs. Again, I repeat, I request non-speakers to mute their inputs. So there have been several studies and analysis and meta-analysis and systematic reviews on the evidence of how these modifiable risk factors work out in causing or staving off cognitive decline. And one of such is published in 2015. The 2017 one will be discussed by Dr. Amit. Now, these are the ones, essentially, the ones which are marked in red, which have a very high, strong evidence. Strong evidence by that I mean that they are established factors and they're definitive risk factors. So if we can avoid repeated traumatic brain injury, whether it be boxers or people who play football, whether we can avoid becoming obese, particularly in midlife around the waist, we can reduce hypertension in midlife. We can reduce smoking, definitely stop smoking, control our diabetes or not get diabetes. These are the most modifiable with definite, risk factors, which if we modify, the level of cognitive decline comes down. Now, what decreases the risk? The level of education. If you are more educated, if you are, learned, if you are doing a lot of physical activity, if you consume a good diet, preferably a Mediterranean diet or a healthy diet, and you use your brain for various cognitive activities, whether it's learning a language or it's learning something new, a new device, a new computer, a new instrument, a musical instrument, these are reducing the risk. That is for mild cognitive decline. For major neurocognitive decline, which falls into the dementia category, again, the ones which have very strong evidence based on the systematic review are avoiding repeated brain injuries, midlife obesity, hypertension, smoking, and diabetes. And in the mild cognitive, major neurocognitive domain, those with established evidence are the number of years of formal education and the amount of physical activity. The others do not have such strong evidence, and we'll go through that. Hence, this is just to show you in the lifestyle, which is again eminently modifiable by behavior, we have obesity, which increases the risk by 1.4. We have smoking, which increases the risk by 2.2. We have physical activity, which increases the, if you have increased physical activity, which reduces the risk, so it's marked in green. If you have a good cognitive reserve, that is your intelligence, occupation, skills, and education, of course, it reduces the risk. If you have low alcohol consumption or no alcohol consumption, also reduces the risk. For medical conditions, if you control your blood pressures, you're going to be good. If you avoid having strokes, you're going to be good. If you control your sugars, you're going to be good. If you control your cholesterol, you're going to be good. There are intervention studies, which is what I told you, the definitive risk and prevention model. So if you control your hypertension, you are going to have a low risk of developing cognitive decline. Reducing cholesterol by giving statins has not been shown to be effective, nor is taking vitamin B12 been shown to be effective. Now, so this is just to show you various pictures of our daycare center, which unfortunately shut down due to the COVID. And these are the activities we do in a chronic care facility. So in the daycare and chronic care facility, elderly people are made to do almost all activities which keep them physically active, mentally active, and contribute by doing, puzzles and games. These are eminently modifiable risk factors. Now, why are we looking at these? Because over the period of years and decades where Alzheimer's research has been going on, we have realized that if we have to have a workable solution to prevent cognitive decline, we have to prevent it. And for that, we have to work on various factors which are modifiable. And this is a statement given by almost 108 physicians from different countries to the G8 summit to implement preventive strategies to kind of stave off or discourage dementia or cognitive decline. And this is possible only with sufficient political will. Of course, the doctors are there are people who are interested in doing this, but then unless there is a sufficient political will, this is really, really very difficult to achieve. Now, how soon do you start? Now, as you can see, this is the timeline of cognitive decline. Your cognitive capacities, they start declining pretty much, at a cellular level, much, much before they are manifest clinically. And the risk factors for them can be before birth, which is your genetic risk factors. And then they are related to your education as you grow. So you can see the timeline, 0 to 20, education, socioeconomic status related factors, life habits like smoking, sedentary lifestyle, hypertension, the kind of occupation you have, whether you have a sedentary occupation or a physically active occupation, the kind of diet you follow throughout your life, and of course, the social networks and mental and physical activities. So the cognitive process is not just limited to, say, between the age of 60 to 70 years. It is something which follows the whole timeline of our life. And hence, as these eminent authors say, that the cognitive health of ours begins right at conception. It begins right from our upbringing till our old age. And hence, the intervention strategies which we have to adopt to prevent this will be to avoid in childhood, please, the parents should avoid parental smoking. They should continue good education for their kids, give good diet and nutrition, exercise, avoid smoking, treat depression, thyroid disease, hormone, vitamin imbalances. As you age, correct your hearing, correct your vision, because if you have impaired hearing and vision, you're not going to be able to perceive and form or get the memory inside, because you're not able to perceive what is being said or seen. Hence, improve vision and hearing as we age. And of course, use your brain even as we age, learn new things as we age. And so this is a whole process starting from conception till we go to from the womb to the tomb. Now, in our country, this is one study, and we are doing another study now, which is being done multi-institutionally thanks to the DBT, to look at risk factors for dementia. And this was a case control study. Now, in the terms of level of evidence, this is a slightly lower than the population-based studies like the Framingham study and the other study which we are doing now from DBT. So this was a little lower in evidence, but then we had studied all factors to look for various risk factors in our population. And you can see significant were the presence of diabetes, depression, having a lot of pickles with salt and oil, having oils rich in saturated fatty acids, having a high BMI, having a ApoE4 and homocysteine, which is high, and the cholesterol, which is high. All these were really, really horribly high in terms of up and there risks to the tune of 4 times the odds, or 5 times or 6 times the odd. Whereas if you were socializing, if you were networking, if you were doing exercise, this reduced the risk. Now comes to another eminently modifiable risk factor, which is diet. And diet works in a multi-pronged way. It works, to reduce the inflammation, that is the gut-brain axis. It offers risk factors. If you're eating a lipid, huge lipid diet, that also is going to be bad. It affects the oxidative pathways in our body. It affects neurodegeneration. It enhances synaptic plasticity and synaptic function if your diet is good. It causes neuronal connectivity and sprouting, which is good for our cognition. And know from various studies, mind, the DASH diet, etc., that if you have a diet which is rich in fruits, vegetables, grains, good oils like olive oils, mustard oil, beans, legumes, etc., a good amount of fish, less amount of red meat, whether it's red meat in the form of beef or in the form of mutton, and very, very less of sweets. Sweets are high sugar is really bad for the brain. You're going to be good in your, cognitive capacities. Then we looked at unusual risk factors. What are the unusual risk factors which can be modified? And one of them we came across through our research coming from the MRI spectroscopy field was the presence of the most potent antioxidant which we have in our body, which is glutathione. And this is research done along with my colleague, Dr. Mandal at National Brain Research Center. And we found that glutathione levels, which is the most potent antioxidant, was depleted in the aging brains, particularly in MCI and Alzheimer's, and this is published. And there are several foods in our daily life like cabbage, cauliflower, Brussels sprouts, mustard greens, broccoli, asparagus, bok choy. These are very, very rich in glutathione containing substances, and hence this glutathione really is something which we are working at, and currently we have launched a clinical study to look at the effects of glutathione supplementation on cognitive decline. So these are things which are modifiable and preventable. Now, again, it's very important that whenever we go for eating anything, we look at various factors. If we are obese, we should obviously avoid processed food and stored food. And of course, control our time on the seat or the chair, like many of us are doing now. And of course, have our normal curcumin, which is supposed to be preventive and prevents amyloid deposition. There's evidence to show that. There's also evidence, apart from a good diet, you have to have periods of intermittent fasting. And this intermittent fasting is supposed to work. It has been shown by enhancing neurogenesis, synaptogenesis, synaptic plasticity, etc., and regulating your autonomic heart and blood pressure functions. So really, you need to work on intermittent fasting along with a good diet. Then, of course, a complete no-no are drinks. And these drinks are your sugary drinks, and dietary sodas, which are definitely not good for, brain health. And this needs to be avoided as we age. The next most important thing, which we really are not able to do nowadays, thanks to COVID, is physical exercise. But all of us can do certain physical exercise like skipping or hopping or walking in our homes if the home is large enough. And how does this physical exercise play out? It has been shown that following an exercise, there is a change in the perfusion of the brain. The exercise modulates various factors which are responsible for autoregulation of blood flow, which are responsible for clearing toxins. So hence, healthy physical exercise like walking, cycling, skipping, whatever your physical capacity allows you to do, should be able to improve your cognitive capacity. Now, the other thing is, of course, the fact that many of us are confined to homes and chairs. And so maybe having innovative methods of finding chairs which help us exercise while we work is something which is going to help prevent cognitive decline. This is just to show you there's a systematic review. So people have studied this extensively, so extensively that this systematic review looked at 1,635 studies done to study the effect of cognitive decline, which is prevented by physical activity. So you can see there are a large number of studies on physical activity, and various kinds of physical activities were taken, including Tai Chi, aerobic activity, etc. And you can see here that with exercise, the executive functions, attention, processing speed improved, memory improved. So really, again, here you see multi-domain neuropsychological performance that improved. So it is kind of modifying cognitive function. But if you look at the strength of evidence or the level of evidence, for dementia, there is no conclusive evidence. There are studies which are going on. There's Finger, and there are some other studies going on in Chicago area, which are looking at the preventive aspects, and maybe we will have the results after some time. So really, there is no concluding data that they prevent, but definitely there is data to show that your neuropsychological performance will improve, your executive functions, attention and processing speed will improve. Then comes the research area of Dr. Suvarna, who's with me here. She's done exemplary work in looking at languages, the effect of learning languages. Time and again, you see this on television. Okay, a person from Tamil Nadu will not learn Hindi. A person from North India will not learn a South Indian language. This is all rubbish. You must know more languages, minimum at least 2, and most Indians know 2 languages, the more the better, because when you're using these many languages as studied by Dr. Suvarna, you're switching between networks, and this is enhancing your capacity to have a network connectivity. So when you're switching between networks, you're keeping your neurons active, you're keeping even your idle neurons which are used in another language active. So bilingualism or multilingualism definitely should be good for our brains, and this is eminently modifiable, and so also is education. The more you learn new things, this is also going to be good. Last but not the least, the last few slides are really softer, softer ones, which we really haven't discussed. The fact that there's research ongoing and published on having a purpose in life. That is, we do know what we want to do with our life, and we are doing something meaningful with positive energy, whether it is, doing something selfless and volunteering within the community, being proactive, being responsible, being supportive to a situation, motivating others, motivating ourselves, and having generally a positive energy in life. This is also very good for prevention of dementia. The other thing is, of course, social relationships and dementia. And the Framingham cohort has clearly shown that the more companionship and emotional support we have and social support we have, the better it is for cognition. Hence, a little bit of exercise, eating good food, and having social networks, family and friends goes a long way. On the lighter side, the last few slides here, it has been shown that countries which eat a lot of chocolate, countries which eats a lot of chocolate is probably the one which manufactures chocolate the most, that is Switzerland. So they have the least amount of dementia. So really, whether it's cocoa or whether it's just the fact it's a lifestyle. I conclude by saying that there are several things which are good for our brain. Let us do it. There are several things which are harmful for our brain. Let us avoid it. Let us look at softer things like our thoughts, our feelings, our purpose of life, our social interactions. And we know for sure that 35% of dementias can be prevented by modifying these 9 risk factors, which are education, obesity, hypertension, etc., which I just enlisted. So really, 35% of dementia can be staved off like this. And there is evidence and there is suggestion to say that we must engage local authorities and commissioners. We must, for a healthy lifestyle to as we age, so that we can delay cognitive decline and we can halve the amount of dementia. Because if we do that, and even if we delay the amount of dementia, delay the onset of dementia by 5 years, there will be a 10% reduction. And there will be a drop in the prevalence of cases, as many countries have seen a drop in the Western scenario. And hence, relatively small reductions in the incidence and prevalence of dementia will have a dramatic impact on public health. And many of these interventions are actually very inexpensive, can be home. They don't require, rocket science. And this kind of knowledge must be given to our community and our patients to empower patients in preventing dementia. With this, I'd conclude. And if there are any questions, I'd like to take them now. Hello. 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 I can't hear. Narinder, are there any questions,
Yes,
Dr. Matthew?
Not. I have unmuted everybody. I have muted everybody. I need to unmute. 1 second. So, yeah, now you can ask. I have unmuted all.
Yes,
Thank you.
Dr. Vinod
Thank you very
Kumar.
much. Thank you very much, Manjari. I was trying to unmute myself. I think everybody was muted because of the connection. So I think we can have spend about 5 minutes to ask some quick questions to Manjari and let her go.
I am Dr. Vinod Kumar. Can I speak?
Yes, sir. Go ahead, please.
Thank you. I must congratulate Dr. Manjari Tripathi for a very exhaustive presentation covering so many aspects how to prevent dementia. She has covered not only physical, mental, and social aspects. She has also given a good slide showing a tree of positive and negative thoughts that in other ways she has also touched upon the spiritual aspect, how to prevent dementia. And it was really heartening to note that she has covered in its entirety. What I would like to add or maybe ask some clarification is that there are certain aspects of spirituality which need further research, because I strongly feel that a spiritual approach to preventing and controlling dementia is also important. For example, there are certain cognitive pathways which still remain intact in early stages of dementia, and they can appreciate the music, they can appreciate incense touch, they can appreciate visual symbols, and this could prevent the progression of dementia. That is number one point. The second point is that all these measures that Dr. Tripathi has narrated, this is reminds me of the entire process of healthy aging. And these measures are applicable to a large number of other diseases which an elderly person comes. When an elderly person comes to me, for example, for advice, he is not going to ask me how to prevent dementia. He is going to ask me how to remain well and healthy in old age, free from uncontrollable diseases of a large number. And all these measures that Dr. Tripathi has said, they all are applicable because this is a holistic approach and they are all cost effective and cheap, as she said, and they would be able to prevent not only dementia but many other diseases. Thank you very much.
There is a question on the panel here. I can ask it. So there's a very good question here, and they're saying that since education and poverty in India are linked, so do you think there are, there is an interaction? See, again, I'm telling you, right in the beginning, I said this is a very complex, it's a multidimensional complex entity. Now, I am not claiming that intervention only in one will prevent. I think it's everything has to go along with each other. So while we look at education, we also have to look at improving the socioeconomic status. The relation of socioeconomic status and cognitive decline particularly has been researched in the West, in the the backward communities, the colored communities, etc. So really there is work done there also. And really, for such a complex disease, intervention only in one particular point may improve. Like, Suvarna study showed staving off by 5 years. Some other study showed staving off by another few years. But if we put everything together, maybe the pushback to the onset of cognitive decline is going to be even huger. So you have good nutrition, you have multiple languages, you have education, you have a good, networking, you have everything. But these are very difficult to research in such a complex manner. You can research a pure entity, like language or exercise. That's a single entity you're targeting. So really, yeah.
So you want to address the issue of...
Can I have a word, Manjari? I'm Renu Vora.
Yes, Renu. Yes, welcome.
Yeah. You were talking about glutathione supplement.
Yes.
And which is, you're still researching on it. I was wondering, is there any supplement available, or you have to get it through the food, as you said?
So as of now, there's a Japanese company which we are associated with, which is giving us the capsules of glutathione, and glutathione is abundantly available in the foodstuffs which I showed you. So we, for the trial purpose, of course, we cannot ask them to have half a kg of broccoli or whatever. We have to give it in a standardized format. Yeah.
Doctor?
Yeah. Any other
Doctor,
questions?
I sent you a message.
You sent
Yes.
a message. Let's see the message. I'm trying to see the messages.
Ayurvedic preparation, Brahmi, no?
Yes,
So,
yes, that is my question.
Yeah, so Brahmi has some, again, the robustness of the evidence is not there. There are a few papers published in some journals, but really when you want robustness of evidence, you need a randomized controlled trial which is blinded. Now that kind of evidence is lacking for any of the Ayurvedic products.
Okay.
And, if we approach the ARDSI Delhi chapter has approached Dabur and has asked them, but they don't want to do it that way. So, you have to have 100 people. Suppose you have 100 elderly people, okay? So you will randomize them by a computer randomization, which the person who's giving the intervention doesn't know which arm the patient is going into or the person is going into. So suppose patient number 1 goes into the intervention arm, which is Brahmi capsule. Patient B or 2 goes to the placebo arm. Now the capsule of the intervention and the placebo have to look same. They have to look same. Even the investigator and the person who's giving the capsule should not know which patient is getting what. And then after a period of say 6 months or a year, you see how many of them develop cognitive decline. So that's how you study something. Now that unfortunately hasn't been done for any Ayurvedic molecule. So it's very difficult for us to comment. Yes, if you look at its properties, if you look at what it does to the rats, it has been shown that it does improve their performance in various cognitive tests.
Thanks, Manjari. I think we have to stop here. I hope you can come back later.
Yeah,
But
so
thank you very
I will
much for
be connected on my mobile. I will be connected
Excuse
on
me,
my mobile.
excuse me. I
Thank
sent
you very
a
much for a comprehensive presentation. We will answer all the questions. Don't worry. If
yeah, I sent a question through chat.
Yeah, we will answer. We'll take questions right in the end. So